I'm gonna kind of shift gear a bit. We've heard a lot about really interesting ways of looking at kidney function in the clinic. And I'm not a clinician, I'm a preclinical scientist, so I'll not be able to kind of dig deeper into that. What I do is actually do preclinical research and work with drug development in diabetic kidney disease. And I think we've had some great advantage, great leaps in drug development for diabetic kidney disease in the last 5 years. I think nephrologists and endocrinologists have their hands above their heads. You know, we have now the SGLT2 inhibitors, the GLP-1 receptor agonists that both seem to protect the kidneys in ways we don't fully understand yet. We also see now that the mineralocorticoid receptor antagonists are also really interesting new targets, new drugs. This comes after a long period of basically very few new drugs coming out, and at least in part that can be ascribed to the lack of good preclinical models where we can actually test new drugs and novel therapies for the patients that we're trying to help. So this is actually what we do at Gubra. We try to set up really great, also very sophisticated, high-end animal models of obesity and diabetes and the associated complications. It could be NASH, but in this case I'm going to talk about today, it's diabetic kidney disease. And what I'm going to try to kind of talk a bit about today is that actually how do we develop these models and how can we combine not only the really cool models that we do with some sophisticated technologies and methods that looks pretty as well. So for those of you who do not know Gubra, Gubra is a biotech company. It's privately held. It's situated up in Hørsholm, just 20 kilometers north of Copenhagen. So at Gubra, we do very early drug development in metabolic diseases and the complications to these diseases. We do our own internal drug development programs, but the main business is actually helping other companies investigate the potential of their compounds and qualify the compounds that they develop before they start to go into humans. So that's what we do. We do not only establish really cool animal models to do this, we also work a lot with advanced imaging techniques. Here's an example where we do deep learning-based image analyses of tissues from the animal models that we use. We also do some really neat, and this is more eye candy, but we can also quantify this. We do 3D image analyses of tissues, whole organs, to visualize single cells, to visualize structures in the organs, and also to look at drug distribution in these organs. So it's nice to know whether you're actually targeting the kidney with your drug, if that's your aim with your molecule. So the two things that I'm going to talk a bit about in this presentation is how can we improve the translatability of our preclinical models of kidney disease, and in particular diabetic kidney disease, and also how can we then use these novel methods I just showed you to explore drug efficacy in these models. So in order to try to mimic what's going on in the human patients, we obviously need to know what's really going on in those patients. And this is a very schematic presentation of the glomerular filtration rate and the albumin excretion in patients with diabetic kidney disease over time. So we see a progressive loss of GFR and then a progressive increase in albuminuria over time. Underlying this are also structural changes in the kidney. In the beginning, it's glomerular hypertrophy. Then we see mild changes of the glomeruli, including mesangial expansion and GBM thickening. At later time points, we see these more advanced histological changes, such as Kimmel-Steele-Wilson nodules and tubular interstitial fibrosis. And some patients, unfortunately, wind up with end-stage kidney disease and will need kidney replacement therapies. So this is all nice. So what does it look like in the rodent models that we work with? Well, unfortunately, most of the models that we work with in general, they only mimic these very early stages of diabetic nephropathy. So we see only mild increases of albuminuria and only early changes in glomerular structures, for example, mild mesangial expansion. What we really would love to see is that these models were actually able to progress into these later stages. And I think a key thing here is actually time. We could obviously leave the animals in the animal facility for 2 years. We might be lucky to see some of them enter end-stage kidney disease. But time is money, and we are trying to work to accelerate this process, so we have to wait a bit shorter, but hopefully still wind up with these advanced changes in the kidneys. So what we've heard about before today is GFR measurements, and I'm not going to talk about GFR measurements in our animal models today because the animal models that are out there, and even the animal models that we work with, they show very little changes in GFR. So it's super difficult, especially in mice, to really have them develop a loss in GFR. So instead of trying to look at that, we spend a lot of time looking at albuminuria instead as a marker of kidney injury, and also the histopathological changes, because we have the opportunity to take that whole kidney from these animals and explore that in great detail. So why is it really important for us that these animal models really do develop these late-stage changes? Well, our PhD student, Frederikke Sembach, who's here today, she actually did a lot of data digging. So Frederikke asked this question, so do we actually see, if we look at the clinical trials that's been going on, and look at the clinical readouts of these trials, how did they compare to the preclinical data that was generated for that same molecule? And what Frederikke saw was actually that the most advanced models, animal models, actually predict better the outcome of the drug in clinical trials. So what you can kind of schematically put it like this. So we have disease progression on the x-axis here, and translatability and predictability of the mouse model at the y-axis. And the very early models, or models that resemble early stage diabetic nephropathy, are these very widely known and used models of STC type 1 diabetes in rat and mice, ZDF rats, and DB mice. So these mice and rats are have type 2 diabetes and obesity. So if we want these animal models to have disease progression and thereby increase their translatability, we apply certain stressors and modulators of disease. Could be doing a urenephrectomy to reduce nephron mass. It could be introducing different diets. It could be a high-fat diet and other diets to modulate the disease. And by doing so, we would actually be able to push the animals and accelerate the progression of the disease to a more advanced disease stage. And here are some of the examples of models that are already out there that show some of the features of advanced disease. So the BTBR or BUB mice, the ENOS knockout DB mice, and then the DB mouse with certain modulators on. And it's the latter model, the DB mouse, that we have taken and tried to really take into a more advanced stage, using urenephrectomy as one modulator and using hypertension as another modulator. Because this is what we really want to do. We really want to mimic the state of these patients. So they are type 2 diabetics, and they also, in many cases, have hypertension. So how do we actually introduce hypertension in these animals? So in this study that I'm going to show you some data from, we took these DB mice, so these are diabetic mice. We urenephrectomized them, so they only have one kidney. And then in order to really accelerate the disease, we also induce hypertension. So the first group here is the control group. So it's injected with this control vector. So it has a almost regular systolic blood pressure of 130 in this case. And then to induce hypertension, we used a renin-encoding adeno-associated virus that we inject, which inserts in the liver and expresses renin at high levels. And we actually see that this really nicely and dose-dependently increased blood pressure in these animals. So that's super cool. But what about the kidney phenotype? Well, it actually follows the same pattern. In the normotensive DB mice, we see albuminuria around 1,000 to 1,500. And then when we induce hypertension in these mice, we are actually able to push that towards 15,000 micrograms per milligrams. So this is really nice. To do studies in models like this, we obviously need a model that's robust, which means that we have to have a certain amount of animals that actually survives all of these interventions. And I'm just here trying to indicate the kind of the dose of the induction of hypertension that we brought on. Higher doses of hypertension actually leads to mortality in these animals. So we want to find that sweet spot where you don't have a lot of animals suffering from this. Histopathology. We have a lot of kidney tissue to work with here, so let's have a look at what that looks like. So this is a PAS stain, a classic PAS stain, where we look at glomerular sclerosis in these tissues. So this is from a normal mouse, if any of you don't know what that looks like. So a normal mouse have nice small glums with basically no mesangial expansion in them. So in the normotensive urinary mice, the BDB mice, so this is kind of a model that's very widely used. We see glomerular hypertrophy, so the glums are bigger. That's also what we see in the early phases of human disease. We also see mild mesangial expansion, so we see more of this pink stuff within the glums, but it's not super pronounced. Now, in the hypertensive DBDB mice, we're actually able to really progress or accelerate this buildup of PAS-positive material in the glomeruli. And I think there are certain structural things in the glomeruli of the mouse that kind of does that we can't really mimic the nodular appearance of the Kimmelstein-Wilson nodules exactly, but I think this is basically the closest as we would ever get to it. So this looks very cool, and obviously we need to quantify this. And when I was a postdoc, I was spending a lot of time in a basement in England looking down through the microscope. And if I could kind of count and quantify 20 glums per mouse, I would be super happy. But here we have a lot more material and a lot more data that we just need to dig out. So how do we go about this without, driving our pathologists crazy? So we obviously want to set up an image app that can actually do the job for us. So how do we do this? Well, we take a lot of pictures of these glums from various mice. Our pathologists have to do a little bit of work, so he would score these, give them a score from, this is a classical preclinical score from 0 being a healthy glum to 5 being or GS4 being a glum with global glomerular sclerosis. And then he would, and this is where the magic happens and where I'm kind of left out in the black box. Then they squeeze all this data into a network and actually use some applications around actually facial recognition, because to the Google Inception network, a glum is no different than a human face. So we actually tell the Inception network that this glum is what a glum with a GS score of 0 looks like, and this is a GS score 3, and so on and so forth. And hoopla, then the network actually knows how to score these tissues. So this is actually what is coming out of the analyses. So this is a whole section from a mouse kidney. Again, it's PAS stained. And here you can see that each individual glomerulus is actually indicated with a dye. So not only is the network able to identify the glomeruli in this section, but it's also able to apply this standardized preclinical score and give it a score from 0 to 4. So this is super cool, saves a lot of time. And we obviously wanted to kind of use this to sort of validate our animal model of diabetic nephropathy, because it's all fine that our model has high albuminuria and has really nice glomerular sclerosis, but it should also kind of respond to standard of cares as a human patient would do. So in this model, we tested the effects of an ACE inhibitor and an ACE inhibitor and an SGLT2 inhibitor in combination to see how they affect the kidney injury. So the first section here is actually the section you saw just before. This is a hypertensive diabetic mouse that's been vehicle treated for 12 weeks. That's a long time in mice. And then the next section here is actually from a mouse that has received this standard of care treatment with an ACE inhibitor and SGLT2 inhibitor. The difference to me is really striking. So what you see in the slide to the left is that we have a lot of these significantly affected glomeruli, these blue and yellow glomeruli with scores 3 and 4. But in the treated section, you see that the glomeruli with scores 4 are basically gone. You see fewer of the GS3 blue glomeruli, and you see actually that the more healthy-looking GS1 glomeruli, the orange glomeruli, is actually appearing. So we seem to have a good treatment effect. We can also show it in a graph that's perhaps more familiar. The first bar here, this is kind of the distribution of the different glomerular sclerosis scores in a section from a healthy mouse. You see that basically all glomeruli are GS0. So in the hypertensive diabetic mouse, we see that there are basically only 20% of these normal or near normal glums left, and all the rest of the glomeruli are really severely affected by glomerular sclerosis. And then when we apply the treatments, you can see that at the bottom, the two fractions of the GS0 and GS1 glomeruli, which are the healthy or near healthy, it actually increases, and you see a disappearance of these very affected GS3 and GS4 glums. Looking at it in a way that you're more used to, in a bar graph, this is simply the very nice treatment effects of an ACE inhibitor and SGLT2 inhibitor in combination in the model. And it also goes very nicely along with the effects that we also see on albuminuria, where we also see this effect of ACE inhibitor alone, and also the synergistic effect between the ACE inhibitor and the SGLT2 inhibitor. So this is kind of an approach to validate the translatability of the model in terms of drug development. So the last bit of my talk here, I'm going to shift gears a bit now and talk a bit about light sheet microscopy, because this is kind of a new technique and a new technology that we've been working with at Gubra. We've been using a lot of time working on the brain and imaging brain neural activation in different regions of the brain. But I also think it has some really interesting applications in the kidney. So kind of light sheet microscopy is a way to do whole organ imaging. So you don't have to fixate and chop up your kidney samples in thin slices. You basically dissect out the whole kidney from the animal that you're working with, fix it, and then you can stain it in two ways. You can either do like a regular IHC stain that many of you are familiar with. Normally you would incubate a section overnight, I think, in the lab, but when you do whole organ imaging, you actually have to incubate for a whole month. So you can imagine how, if you're doing optimization of stains and testing new antibodies, how that can kind of be a time-consuming thing. So the other way around that, the other way that you can actually label things is actually by injecting tracers or compounds that are labeled with fluorophores in the live animal, and then you simply, after a certain period of time, take out the organs, fix them, and then you can actually image them straight away. So that's a bit easier, but also has its limitations. So what's kind of the whole thing about this is actually we fix the tissues, we label them, and then we do this clearing step. And the two images at the bottom of the slide shows what clearing is all about. So basically we make the organ disappear, it seems, but it's still there. There's a small shade. So this is an example from a mouse brain that's cleared. So the actual tissue is actually you can see through it. And then you pop it into the microscope, and then the microscope does the rest. So here, in this first example, we have taken some regular mice. We've injected them with a tomatolectin that binds endothelial cells. And specifically, it binds very strongly or with high intensity to the glomeruli of the kidney. So here you see, this is basically raw data when all of the scannings from the microscope is stitched together to raw data set. All of the gray dots here are glomeruli. So the next step is actually a bit more sophisticated. This is where we can actually apply a unique identifier to each individual glomerulus in the kidney. So we would know exactly how many glomeruli are in there and where exactly they are localized in the kidney, and also localized compared to each other. And finally, we can do in this case, we've done some morphometric analysis. So here we would actually, here we have color-coded the glomeruli according to the volumes. So I think this is common knowledge, but still it's a cool way of showing it, that the blue scale, the smaller glomeruli seems to be situated out in the outer cortex of the kidney, and when you go in towards the medulla, you see the glomeruli bigger. So this is basically a proof of concept of how we can do image analysis like this. We obviously also wanted to use this morphometric assessment in our animal model of diabetes and hypertension and see how it actually responded to these standard of cares. Again, we have the control kidney, the DBM kidney, the healthy mouse. Again, we use the same color scale, so these blue greenish glums, they are small and nice and healthy. So that's very apparent here. And then when you look at the hypertensive diabetic mice, you see that the glomeruli are more into these red and yellow colors, indicating that we see really extensive hypertrophy of the glomeruli in this model, which is not a surprise. And then again, when we use these two standard cares, the ACE inhibitor and the combination of the ACE inhibitor and the SGLT2 inhibitor, we see actually a color shift towards this more healthy appearing green and bluish color. And we can actually quantify this. And this is a horrific graph, I know that, because so what I really want you to notice here is kind of the gray curve. That's the healthy mouse kidney. It has a really homogeneous. You can see that on the width of the graph. It has a homogeneous population of glomeruli, which are small, which is indicated because they are on the left of the curve. Then if you can kind of look at the black bar, that's the black graph, that's the hypertensive diabetic kidney and the glomeruli. They are shifted toward the right, meaning that they have hypertrophy, and also the distribution is wider, meaning that we have a more heterogeneous population of glomeruli. And then if you look at the pink graph, which is the combination treatment, you actually see that the treatment is pushing the kind of the distribution back towards the healthy state, meaning that our treatments in this model actually also affects the hypertrophy of the glomeruli. So this was morphometry, and what would obviously be super cool is also to look at function. Still, this is an organ you take out from the animal, and we fix it, and so we can't do live imaging on the organ after it's dissected. But what we can do is kind of take advantage of the fact that we can inject things while the animal is still alive. Here we've injected, again we have injected this lectin that's kind of stains the glomeruli. You can see them in blue here. I hope that we can play it again. And the yellow color here is actually albumin, labeled albumin. So again, this is common knowledge, but I think it's super nicely shown here that albumin, even in the healthy rodent kidney, which this is actually filtered to some degree through the glomerulus, and it winds up in the proximal tubule and is really nicely reabsorbed there. And this is actually what we're showing right here. And what's really, I think, really nice to see here is that we can actually see how the proximal tubule over here on your right-hand side is actually really nicely attached to the glomerulus. So this is what a healthy organ looks like. But what does it look like in our model of diabetic nephropathy and hypertension? So this is a healthy mouse kidney. Here we have again the pink signal is the glomeruli. The green signal is now albumin. So here you see basically no albumin in the kidney as such. You see some in the renal pelvis. I think that's kind of where it should end up. This is a diabetic unioneffectomized mouse kidney. You see, if you look really carefully, not only do you see hypertrophy of the kidney, but you also see small dots of green indicating a leak of albumin. And then if we look at our unioneffectomized DB mice with increasing blood pressure from left to right, we actually see that the flux or the filtering of albumin is significantly increased in these kidneys. This is basically another way of looking at albuminuria, but this actually gives us impression that the glomeruli are very heterogeneous in these sick animals, and the patchiness of this kind of green leak of albumin really shows us that you might have a corner of the kidney that looks almost healthy, while other areas are significantly affected by disease. And a final way to show this is using a tubular damage marker. Albuminuria is obviously focusing on the glomerulus and filtration of albumin there, but we're also interested in the tubules and looking at damage markers in them. This is a KIM1 stain in a hypertensive diabetic mouse kidney, and what you can see is that the white patches is extremely high expression of this marker. So we see, again, a very heterogeneous expression pattern of KIM1 damage marker. And then when we look at the healthy mouse kidney compared to that, so again here the green dots are the glomeruli, we see basically no KIM1 positive nephrons here. Actually, we do see 2. And when we do kidney sections on these kidneys, we don't see anything. And that's simply because there are only 2 in the whole kidney. So the chance of finding these is really minimal if you do 2D. But what's really interesting that it was at least my perception that we would see no KIM1 in a healthy mouse kidney. So even in a healthy mouse kidney, something is actually going on. So using these tools, we can actually now start to look at effects down to the single nephron. We are also working on a glomerulus damage marker, so we can actually look at, okay, if we have a lot of KIM1 stain in the proximal or in the tubule, is that connected to a damaged glom, or is there no connection between damage in the glomerulus and damage in the tubule? We actually don't know that down to the single nephron, and that's to me a really interesting path that we could go down. That was the final slide. I just want to acknowledge the work of some of my teammates who are here today. This is a really joint effort. I think the names here are both in vivo pharmacologists, it's biochemists, it's data specialists and histologists. So thanks for all of the efforts from you.
Thank you very much, Mette, for this very, very exciting presentation. Hopefully you have been enlightened to have some questions.
Yeah, it's almost time for coffee, right?
Yeah, thank you for a nice presentation. Do you know whether these findings in your imaging techniques correlate with some of the biomarkers that maybe was shown earlier today, or such as super, or for instance KIM1 or NGAL, or some of the usual suspects?
So what I didn't show is that we have actually looked at KIM1 in the urine, and that correlates nicely with KIM1 when we do 2D histosection. So the KIM1 stain I just showed you in 3D, it just came out of the lab last week. So still data analysis pending. But just to say that these markers do correlate nicely. What we are still missing are these markers of actual kidney function, GFR loss, right? And that's kind of the headache with these models, that we need to hit them really hard for them to begin to lose GFR. Stine, who's a postdoc in our group, is working to tweak the models a bit. There is a classical model of CKD, the 5-6 nephrectomy model. And that's one extreme, and then I think our diabetes model is the other extreme. So we're trying to perhaps see if we can kind of do a morph to really get this GFR loss in the model, which would be superb.
I had a question first regarding the physiology in the kidney. Are you able to actually, for example, measure tubular glomerular feedback, which would be really a big achievement?
That would be a big achievement.
If you could do that.
So I think that would be kind of where you would do kind of these single nephron puncture things. And to me, looking at the histology of these kidneys, looking at, even in 3D, we really appreciate how heterogeneous the nephrons look, and probably also how they function. So doing single nephron stuff in these mice, you could be lucky to hit one of the almost healthy clumps or nephrons, but you could also be unlucky to hit a nephron that's kind of basically deceased. So it would be a tricky thing to do. You would need to look at a lot of nephrons to get robust data from it. Yeah. But it would be interesting.
Thank you very much for a exciting presentation. We would like to invite to Spain.
I'll be happy to come.
Oh yeah, after the summer, it's possible. Yeah.
Or in the summer,
Okay.
I don't care.
On summer, is the same. Okay, we like 2 comments and or 2 questions. One of them is, okay, we are talking about the glomerular lesions, tubular interstitial lesions, and vascular lesions. Where are the vascular lesions? Because I think it's very important to develop decline of the GFR or cardiovascular events in humans. And the second question is, have you any experience with combined ACE inhibitors plus GLP-1 receptor agonists?
To the last question, yes, we do. We have some data where we have looked at the effects of combined treatment with lisinopril and semaglutide. So I don't know whether they are to be published, perhaps, but I think, yeah, and we see, I would say, expected effects of these treatments. My next, on my to-do list of treatments that I want to look at is obviously the combination between an SGLT2 inhibitor and finerenone. I think that would kind of, be super interesting. For your first question, I think so as scientists, I come from a very podocentric lab, so I love the glum and it's very fascinated about that. I know other my colleagues are more tubular-centric, and obviously we need to look at both compartments, right? This is also why we're now looking at this tubular damage markers. I think they're super interesting and open up a kind of whole new space to explore. And then we tend to forget the nerves and the vasculature. And these are super difficult to explore, but actually we have just established stains, so we can look at them in 3D. And I think that's what you need to do. I think you have to look at them in 3D to get an impression of what's going on. Do we see rarefaction and all these things? And what we're actually able to do right now is that we can look at the different compartments separately. So we have a stain that can kind of capture the peritubular capillaries. We have a stain that can capture the glomeruli and the arteries, and we do have a stain that can actually also image the nerves that goes along these. So the next step, and I think this is also very crucial to note. Obviously, it's a lot about biology, and we can understand the models, but we can't do this without our data scientists, because they are the ones who are able to kind of tease out the data from these really cool videos, but it's just a video, right? You need to be able to quantify, and that's actually the next great step, and where it also takes a huge effort for them to do that. Yeah. Mm-hmm.
Yeah, I have a question as well to your techniques. Thank you for a nice presentation and also going through these nice techniques. I was wondering, when you do the method with Inception and Google, and you quantify the stages of the disease, how do you validate the model, or can you comment on how you validate the model?
Yeah, so that's a very technical thing, and I would actually prefer to put you in touch with some of our data scientists. But what we actually do is that we do these, so every time we do scoring of say, a big study, 5 treatment groups, 100 mice, we always take out 10 or 20% of the glomeruli that are actually scored manually by our pathologist. So that gives an idea of whether the app is performing as it should, and then and that's basically how we can kind of do that. And I get from our data scientists that it actually takes quite a lot of managing to keep these to maintain these apps. What's also super cool is that we also work with other models of glomerulopathies, such as anti-GBM nephritis, and also models of FSGS. And we can actually apply this app to these different models, and we really see that in the diabetic model we have a lot of sick glums, but in the FSGS model we only have 10% of the glums that are affected. So that model also works as it should. So.
Well, thank you very much. It was wonderful. Seeing this picture was amazing. Just a comment link with Enrique. You proved that the glomeruli were very much affected. do you have fibrosis at the same time, tubular interstitial fibrosis, or just glomerular damage?
Yeah, and this is where you're pulling your hair out, right? Every time we get the histosections from these models, you know, you run to the lab and look down the microscope and you see the stunning glomerular sclerosis, and you're thinking, where is the tubular interstitial fibrosis? But it's not really there. So we have done stains for, say, collagens, collagen 3 or collagen 1, and we do see a little bit of higher expression, but we don't see these, I would say, real tubular interstitial fibrosis where you see thickening of the basement membrane of the tubule. They get kind of an irregular shape, and you see that the tubules are really spread out by actual deposits of fibrosis. We don't see that. And this is kind of the tweak we need for the GFR to go down. Yeah,
Exactly.
that's absolutely
For
true.
how long do you have the model?
So the animals are 24 weeks of age when we take them down, so that's quite old. And we start the induction of hypertension and the urinary I'll do the math, 16 weeks, so around 8 weeks of age. So they're actually hypertensive and have a urinary for 16 weeks. Yeah.
Just males or
It's actually only females.
only females?
Yeah, so we use females because in the DBDB mouse model, we actually do see quite a lot of hydronephrosis in the male mice. And that kind of confounds and destroys whole studies. So Frederik actually did a study where she compared, not this model, but in the DBDB UNX model, where she compared male and female mice, and we saw that the progression of disease was very similar in the two models. So we decided to go with females to avoid this confounder.
Thank you.